компютър. Morat ću da okrenem nije. Kako bih video.
Znači ne vidi se ovo.
Mutno se vidi. Pa da ja nemam što mnogo, ja znam što ti treba da pričam.
Okreni.
Da, to je sad, znači ja ovako kad stojim, gdje gledam? Razumete?
Pa dobro, okreni se malo tako, da. Da.
I onda moram i tako monitor da okrenem sebi.
Pa okreni. Mislim, to je problem, ne razumeš, rekao si mi, bar još jedan monitor da stave.
Okay.
Welcome to the last session today. Thank you to be here with us at this last moment. And it is my great pleasure to introduce Dr. Nikola Stojanovic. He is a medical doctor, University of Niš, and he is actually dermatologist. Psychiatrist, and he will talk about chronic fungal infections in Tertiary Care Center for Mental Disorders. Please, Nicola.
So, hello everyone. She stole my entry. Well, yeah, I'm a medical doctor and I'm a psychiatrist. And I come from the Clinical Center Niš, Center for Mental Health Protection. Can you connect psychiatry and microbiology, mycology? Well, I think I can, and that we can, and well, I'll try to show you how from my point of view. Yesterday at the lunch, I talked to some lecturers and it inspired me to change a bit, some introduction of my presentation. The first part is I worked in the laboratory medicine at the Department of Physiology, Faculty of Medicine for more than 10 years. In 2024, I finished that and started doing psychiatry. A few years before, but yeah, that 2025 is the moment that I quit and went to do the clinical work on the psychiatry. But my first love and generally love for laboratory medicine never stopped. I'll try first to remind you what is connection between the body and between psyche and how I see the body. At the beginning, I like to remind you that skin, although not dermatologist, and brain are quite deeply connected. If we remember embryology, the leaves that these two structures develop from are the same. So that's the ectoderm. If we know it from the embryological area, and at the time when the fetuses are developing, if we know that then there is a connection, why don't we think that there is a connection when we are human beings, adults? We say that a lot of people are burdened by mental issues. I would like to stress out something is mentally disturbing someone and something is a disorder. So we say 1 in 8 persons have mental disorder. Many of them have mental issues. So that's something that is on daily basis provoking the dysfunction of our central nervous system. So we have normal stress and we have acute crisis. And in between, we have, so to say, disease. Disease is interfering with our daily life. So disease is making us dysfunctional. Briefly, to remind you, I know psychiatry was very long ago, but there are some clusters of disorders. So anxiety disorder, mood disorder, psychotic disorder, behavioral eating disorder, and personality disorder. Here I'll just mention some of them because there is not much time that I can go in details about each and every one of those and how it's connected with fungal infections. I guess you remember all of them, experienced or seen someone with them. In psychiatry, we have something called biopsychological model. Long ago, in time of Freud, we wanted to be everything like a fairy tale. trying to explain everything from the point of mental, so from the point of psychology. Now we understand that it is much more complex, that it has a biological background. What is symptoms that we observed in patients? We observed the mind changes, the changes in behavior, and the last part, the body. We most certainly observe the symptoms that patients are explaining, which are, as we say, somatic. So something that the patient is complaining about. This is an algorithm how we diagnose a mental disorder, and I would like to stress out of the first square. So, by a primary care doctor who sends a patient to a psychiatry. Sometimes, very often, patients refuse to go because we think we're not mentally ill. But I think that psychiatry and somatic medicine intertwine here. So, are we sure that the symptoms are not caused by any medical condition? During the last day and today, we talked about how the brain and other organs are connected, although not explicitly, but indirectly, mentioning the gut as the source of different microorganisms and mentioning the skin. These structures are really indeed connected. And by secreting molecules or directly invading the systems, these microorganisms could affect brain and its function. So we know that there is much more microorganisms in our guts than there is cells in our body. A large portion of that microbiome is bacteria, but small portion are fungi. It says 0.1. And that 0.1 is relatively active. It produces a lot of molecules, and a lot of those molecules are very, very actively influencing the brain. So there are 3 steps. The first step, or the first path that they go, is by breach, by overgrowth, and by initiation of inflammation, by secretion, so by destructing the endothelial barrier of the guts and entering the system. When they enter the system, they enter through different molecules, triggering immune system, and again they reach another barrier between blood and brain, disrupting it, entering the brain. And that's all coming from your intestines. So we know that the connection between the brain and the guts is very strong, and we see that in patients with addiction. If you're consuming large amounts of alcohol, there is a disturbance in microbiome, and that disturbance is seen as the change in the Candida and Pichia in the samples of those patients. So we know that potentially a disorder that we see is connected with a disbalance in these microorganisms. Again, in schizophrenia, we have something called Candida dominant enterotype. So patients suffering from schizophrenia have different profile of Candida in their microbiota. Is that a cause or a consequence, or just a coincidence? We really don't know, nor we understand nowadays. That's about gut and brain connection. The next connection is the connection between the skin and the brain. It's a story where in psychiatry, patient refuses to go, but in dermatology, patients demand to be. And through my case, the next one, I'll try to help you understand how these two are connected. If you remember the 4th slide, I think, with the psychiatric disorders, there's a psychiatric disorder called psychosis, and one of them is the delusion. And we have fungal-related delusion. What is the fungal-related delusion? We have a patient, 54 years old. The patient has a history of 7 years going to the dermatology, claiming he has fungal infection. And he's telling you the fungus moves from one part of my body to the next at random. I can see the spores in the morning in the sunlight, and I'm reinfecting my eyes and my lungs. That's the patient telling to the psychiatrist. But the patient is referred to a dermatologist because he is complaining he has changes on his skin, on his eyes, and he's constantly pushing those changes. After 7 years, he is referred to a psychiatrist. The next slide will explain you how we can interpret everything through a change in a psyche and everything as a normal behavior. So the patient is saying, I have sensation of webbing over my eyes. We would say it's a hallucination. I have feeling bugs traveling through my feet to the scalp. That's a formication. That's again another hallucination. I'm seeing the spores on my skin and the changes. So we will say that again, it's a delusion. And I'm rubbing my skin because I want to remove the fungus from my skin. That's a compulsive behavior. So the point is the patient is not recognized by a somatic doctor or by primary care as a psychiatric patient, but he is being told to go to a dermatologist. You all work in lab, I guess, or some of you work in microbiological labs. Have you had patients bringing you samples of their own, saying, this is from my skin, this is the fungus, I want this to be tested, I collected this, this is the sample, and I'm sure you will find the cause of my infection here. They bring that to us as well, these kind of patients, showing us, see, this is the fungus that I'm talking about, or this is the parasite that I'm talking about. And those are most often some skin excoriations. Those patients should be referred to a psychiatrist. So after 7 years, patient finally ended up in psychiatry. But before that, he went through a circle trying to find a cure for the fungal infection that he was convincing to be having. In psychiatry, we know of these and similar cases really back in 19th century, and the final classification says it's delusional infestation. But we know that this is happening, that this syndrome is not as rare as one might think, since it ended up in classification of disorders. Previously, it was called ECOM syndrome or pseudoparasitic dysesthesia, but now we covered all the delusions related to infestations on the skin. So this is one end and one type of story that psychiatrists can see in his own practice. The second story is a person who has these changes. These are not delusions, I guess. Well, I'm not a dermatologist, but I guess this is a nail infection and this is a skin infection. So it's not a delusion. The person comes and says, look at my hands. I have this on my nails. And he's showing this. So this is an infection. You go through life with that kind of change on your nails. So you go to work, you have a partner, you have a friends. How do you feel about those changes on your nails? Are they disturbing you? Are you trying to hide them? Do you think that that everyone are looking at your nails? Are you feeling ashamed? Are you feeling disturbed, anxious? Are you feeling sad? What are your feelings? You cannot be totally indifferent. You must think that something is wrong with you. So apart from a real mycological infection of the nails, you are having accompanying psychiatric disturbances. So if we think, and we know these are not acute changes, so it's a chronic infection, So if these chronic infections, how long are you mentally suffering from the unbearable change, unbearable experience that everyone are looking at your nails? That pushes towards anxiety disorder, and that pushes towards depression. So yes, patients suffering from fungal infections, especially visible ones, are suffering also from either anxious or depressive disorder, or at least have some of the symptoms, because these changes are really disturbing for them. So they should be treated by a psychiatrist as well, depending on how lost. If these changes are, for example, 2 years, that patient must have developed depression for sure. He tries everything, the infection is there. So one is the impact of the mind on the skin, and the second bottom loop is the impact of the skin on the mind. So they're intertwined. And as the second slide says, because they're ectoderm, they're coming from the same structure of the neural crest. At the end, I would like to acknowledge or to mention just a paradox. If you're treating an infection, trying to stimulate our body to fight, and at the same time our patient is having a depression or anxiety, where the cortisol levels are spiking, how do you think that immune system is fighting? How do you think that when you apply an antibiotic or some therapy, how do you think that that immune system will fight the invasion of the pathogen? Well, not pretty good, I would say. So again, should we only treat a chronic infection with just an antimycotic, or should we include a psychiatric treatment? That's something what you should think about. So yesterday and today, we were all talking about no shoe size fit everyone. So to find every different cure for a different person, I'm thinking that we should approach every patient as an individual, not just for a therapy for microbial infection or fungal infection, but as a patient, so as a person who is a singular, with different needs, with different requests from you, with different approach, what you should do and how should you treat him. So algorithm, is it always adequate for everyone? I don't think so. And we constantly fight algorithms in psychiatry. We do have them, but we fight them because we know that every person is a story for himself. And at the end, progress is possible, but it happens to be a personalized pace. So it needs a specific personalized approach. And at the end, I'd like to say congratulations to Professor Valentina, because she made a small step creating an app. And I myself want to congratulate myself for convincing her to add a section of the somatic illnesses where the psychiatric illnesses are included as well. So when you are filling the app and when you're examining the patient, apart from the examination and sample collection, there is a part where you should say, is the patient suffering from some somatic illness? And there I placed 2 psychiatric disorders that are frequently associated with fungal infections. Thank you for your kind attention. Now I'd like to call Professor Valentina once again to deliver her presentation.
Thank you, Nicola, for great presentation and connection between these different fields of medicine. You bring a fantastic connection, and maybe one day we will have a new way in medicine called psychiatric mycology or mycological psychiatry, something like this. In the end of this educational symposium or postgraduate course, I will show you a few cases from Serbia. We established our reference lab almost 20 years ago. And at that time, usually laboratory proven for invasive fungal infections was very rare. Hemoculture, positive hemoculture was one way, and the other was cerebrospinal fluid examination, usually for cryptococci, and blood culture for Candida. And thanks to Professor David Denning, in 2011, we published in journal prevalence of superficial fungal infections in Serbia, as well as prevalence of invasive fungal infections in Serbia. And I present this data here, but publication is available for all of you. From that time, I was focusing mainly on invasive fungal infections, but it was very logical that they must come from somewhere, especially from skin and mucosa. And I decided to find this connection and to look much more at the prevention. The second very important issue is biofilm forming fungi, as well as other microbes. And proven evidence that more than 80% of chronic fungal infections or complications or long-term lasting conditions are caused by biofilm forming fungi. Here is data regarding invasive fungal infections in Serbia and estimated number based on exact number of high-risk patients. We check epidemiological data regarding high-risk patients and calculate how it will be in 2016. Also, we used to use this Gafi platform for education of our clinicians. Also, we built Serbian Society of Medical Mycology, as I already told, 20 years ago almost, and we start to organize every second year a national educational meeting, diagnosis and treatment of fungal infections. And I will start with our first case. The case one is from 2011. Here is some data regarding patient, but at that time we started to use biomarkers, early laboratory biomarkers. First, Manan to find Candida invasive infection, and Galactomannan to find Aspergillus. And we found in one old man with acute myoplastic leukemia low positive Galactomannan. Low positivity of Galactomannan sometimes can mean false positive results. But CT scan was very characteristic, as you can see here, and primarily diagnosis made by our physician was invasive pulmonary aspergillosis, and they start with voriconazole. But nothing happened. Still Galactomannan low positivity. and no clinical benefit of this treatment. Then patient underwent bronchoscopy and by cytology. Okay, this is some other also findings. And we found, pathologists examined the lung tissue and the non-septite hyphae demonstrate. Non-septite hyphae usually means or can be related to mucorales or mucormycosis. And do you think which identification or which diagnosis we can make by after this demonstration, and which treatment? Any of you? If we suspect mucorales or lung fungal mold, non-aspergillus, because usually more than 80% fungal mold infections are related to aspergillus. And usually treatment with voriconazole is very successful. Anyone? But for aspergillus, hyphae is septate. For mucorales is non-septate, and mucorales are sometimes resistant to azoles. And the drug of choice will be which one? Sorry? Yes, great. Amphotericin B. Any time when you are not sure and stop azoles, because these drugs usually are fungistatic, and switch to ampho B, because ampho B is usually fungicide. And definitive diagnosis will be first A, B, C, or D? B, great. Then case 2. About patient, okay, you can, all these presentation will be in ECMID library, then you can follow up more in details. I will pass to the clinical findings, because for pulmonary localization, clinical findings in invasive fungal infections are not characteristic, but here we have something like this. Patient with esophageal cancer treated with cytostatic, and surgeries isolate the patient suspecting anthrax. But one colleague, hematology, comes to visit her mother, and surgeons ask she come to look the patient, something unusual happened, and she just call Valentina. We came there and we says, okay, it must be what? Highly immunosuppressed patient with rhinofacial symptoms and signs of disease, like this necrotic lesion. Mucor, yes, great. This is maybe the only one or very rare infection with acute stage of disease and characteristic rhinocerebral form. And if you understand the patient history, medical history, and treatment, you will easily suspect mucorales or invasive mucormycosis or zygomycosis. But surgeries told me, wow, I don't believe you. Okay, let's come to the computer and find Professor Petrico's presentation. And when I showed this presentation, he told me, okay, great, now I believe, and what is the next step? We take the sample from this necrotic lesion, but it is life-threatening disease. There is no time to wait for the laboratory diagnosis to prove, and we suggest, okay, we take the sample and now we will do the best, but we suggest you to start the treatment immediately. Which one? Which antifungal drug you will suggest for mucorales? Again, Ampho-B, great. And we start. And you can see the fantastic outcome of this treatment after 5 days, after 10 days, and after, I think, 14 days. Also, from the other side, and this. This is wonderful drug if we precise suspect the causative agent. And the question is A, B, C, or D? Again, D, great. Case 3, children from hematological units, Novi Sad. With skin, okay, again, with Hackman catheter, with fever, and with blood culture positive for Staphylococcus, started with antibacterial drugs. But dermatologists found vasculitis, cutis reactive, and also in blood culture, few days later, molds is isolated, and by analyzing under the microscope, it was Hyaline molds. Galactomannan was positive. What you will suspect? Positive blood culture and positive galactomannan. Nobody knows? Galactomannan is usually positive during invasive aspergillosis.
Yes, maybe CGM positive, so that's why we are silent.
Okay.
I don't think I'll try.
Sorry? Great. Remember this. Take this message home. Beside aspergillus, invasive aspergillosis, also invasive fusariosis give the positive galactomannan. This is the clinical findings also, and this was the isolate from blood in our lab and microscopic identification. These characteristic culture findings and microscopical findings suggest us fusarium. It was time that we was without Malditov. Okay, and the answer will be A, B, C, or D. Again, D, the right answer is Fusarium sepsis. And with these cases from interesting, I believe that you learn something new, or maybe you can introduce this in your practice. I would call you to come in Romania for Balkan Fungus 2020-26 from 1st to 3rd October. And also, I want to remember somebody of you that we decide to organize this regional meeting in 2017 when we was the local organizers of trends in medical mycology. And from that time until now, this is the fourth one, and I hopefully all of you will participate. Thank you very much for your attention, and I ask Nicola to put the last presentation, and then we will conclude this session and go to the practical work. Thank you.
I think that the colleague
Hello everyone,
who introduced
I am
herself.
Dr. Isha. I am a resident doctor working in general medicine at Peterborough Hospital in the UK currently. Firstly, I am very grateful for this opportunity to present and share my key insights about this topic with you. The topic of my presentation is preconception counseling in women with recurrent vulvovaginal candidiasis. Let's dive into it. Let's talk about the overlooked burden of RVVC before pregnancy. Vulvovaginal candidiasis is often perceived as a minor or routine gynecological infection. However, for a substantial group of women, around 5 to 8%, the disease becomes recurrent and significantly impacts the quality of life. This condition is commonly defined as 3 to 4 or more symptomatic episodes annually. This has a significant impact on the patient's quality of life, sexual health, mental well-being, and fertility planning. The burden extends beyond just physical discomfort. Women frequently report chronic pruritus, dyspareunia, sleep disturbance, emotional distress, and frustration related to repeated treatment failure or recurrence. Let's understand the pathophysiology and a few risk factors. So the common organism that causes candidiasis is Candida albicans in about 80 to 90% of the cases reported. The key risk factors include recent or frequent antibiotic use, which can disrupt normal vaginal flora. A few medical conditions like diabetes, hormonal changes, or immunosuppression, including HIV or steroid use. A recent study in 2025, which was published in the International Journal of Medicine and Pharmaceutical Research, showed that pregnancy associated with this condition is not always straightforward. Species identification, antifungal susceptibility, and biofilm formation all matter clinically. And an important message, this condition is not due to poor hygiene or sexual transmission. There's much more to it. We all know that this disease has a global prevalence. Despite that, it is often under-recognized as a condition. Beyond the clinical symptoms, IVVC has a hidden socioeconomic impact. Repeated episodes can affect the quality of life, sexual well-being, relationships, and mental health of the patient. Women also experience repeated healthcare visits, prescription costs, over-the-counter treatments, and time off of work or study. This burden is often underestimated because RVVC is not usually life-threatening and may be normalized or even self-managed in most of the cases. Let's talk about why preconception counseling is essential. Discussing RVVC before conception allows clinicians to review the patient's recurrence pattern, confirm the diagnosis, identify any modifiable risk factors such as diabetes or antibiotic use, and optimize management before pregnancy. Preconception counseling also gives patients clear guidance on symptom recognition, safe treatment choices, and when to seek medical review. Overall, addressing RVVC before pregnancy supports better symptom control, reduces anxiety, and helps patient enter pregnancy with a safer and a more personalized management plan. Now that we've established why preconception counseling is essential for patients, let's talk about the approach to counseling. This is a 5-step counseling framework, which is a practical way to counsel women. First, confirm what we're treating with, then reduce triggers, plan medications safely, and address the impact on daily and sexual life. What I'm trying to say is the aim is not simply to prescribe an antifungal, but it is also to create a confirmed, safe, pregnancy-ready plan that also recognizes the social and sexual burden of the condition. A few effects of counseling. Counseling addresses the emotional and social burden of RVVC. Patients may feel embarrassed, often blame themselves, avoid intercourse, or worry about the recurrence. So counseling improves confidence, relationship communication, quality of life, and appropriate care seeking. Overall, counseling transforms the condition from a repeated cycle of symptoms and self-treatment into a more safer, more informed plan that supports the woman, her pregnancy, and her wider well-being in general. To conclude, RVVC is more than just a yeast infection. It has a significant impact on physical comfort, emotional well-being, relationships, and quality of life. Through early recognition, preconception counseling, and patient-centered care, we can improve support and outcomes for affected women. Remember, preconception counseling in recurrent vulvovaginal candidiasis is not only about infection control, but it's also about improving reproductive confidence, pregnancy safety, and quality of life through individualized care of the patient. For the people who are keen to learn more about this condition, here are the references that I've used for this presentation if you're interested. And lastly, I would like to thank you all for your attention and time today. Have a great day.
Any discussion, question, comment for these last 3 presentations? Okay, then we can conclude this session and to move in the other room for the practical work. If you want again to see these new tools and software and mobile app, I kindly ask you to fill this survey, which you will receive on Monday or after Monday from the ECMID. This is the obligation in order to get the confirmation that you
Yes,
Yes.
you will distribute it through the email. So after you complete it, you will receive the certificate.
and any of suggestion how to organize this better in next period, we will we want to hear from you. And also finally, I really want to thanks to all of you coming Belgrade to join us in this educational postgraduate ECMID meeting, personalized mycology. And again, I like to see all of you in Romania in a few months. Nicola helped me very much to organize this and other my students, but really I would like to thanks Nicola for great help.
Thank you for inviting me and for giving me the opportunity to help. Yes.
Now we can move in the next room to show again the... Probaj da vidiš, to su ovako.